Welcome to Rush University, Rush Medical College, where you will become the doctor tomorrow needs. Now, this video is going to be based on our practitioner rule. Namely, we're going to learn the skills of clinical thinking, or at least start. It takes years to develop this skill, but let's go start with an introduction. And the best place to start is always with a patient. And this patient here seems to have a headache. And with clinical thinking, our goal is to start with the patient's problem and then move to a diagnosis that we can treat. So how do you do that? Well, that's the whole thing of clinical thinking. And so I've depicted it here as a black box where you take the patient's problem as input and output is a diagnosis that we can treat. And what goes on inside that black box is the whole process of thinking like a doctor. And it basically boils down to doing two things. You gather and interpret data, and then you make and test hypotheses on that. And in medicine, the hypotheses that we make are called diagnoses. And when you test these diagnoses or hypotheses, you're going to do one of three different things with it. You're going to decide that the patient doesn't have that diagnosis, in which case you could trash it. Maybe you decide that the patient does have it, in which case you're going to treat it. Or you don't know whether they have it or not, and you need more information, so you're going to need to get more data and test further. So you're either going to trash it, treat it, or test further. So let's go through this with a very simple case. It's going to be a simplified version of our patient who comes to us complaining of a headache, and we need to figure out what to do. So I'm going to put our people down here so we don't forget about them. And the first pieces of data that you get come from the nurse who talked to the patient initially, and he or she took down some information that the patient's coming in with a headache and took down some vital signs, which are some measurements that we can get, which you will learn. There's a blood pressure here, which is 140/80, which is a little bit high. The heart rate is 110, which is a little bit high. Respirations are 20, which technically are a little bit high, and the temperature is normal. So we've gathered some data and we've interpreted it as well. We said that some of these things are high. And so the next thing is to make and test hypotheses. So we have no hypotheses yet, so we need to make some. So your intuition looking at this patient makes you think, this is making me think that this person has bleeding aneurysm. There's something about this patient, maybe the way they look, maybe it looks like prior patients that you have seen before. This patient looks similar to that. But you're not going to rely solely on your intuition. You also have a systematic way of looking for hypotheses that you want to consider. So you want to consider some deadly things as well as some common reasons that a patient may have a headache. So some deadly diagnoses you're going to consider are things like a brain tumor or a brain infection called meningitis. And common things you are considering are migraines and sinusitis. And so the common diagnoses are migraines and sinusitis. And so now what we've done is we've constructed a list of potential hypotheses, including a bleeding aneurysms, tumors, meningitis, migraines, and sinusitis. And given this information that we have here, that the patient has a headache and these vital signs, can we say with confidence that this person does not have a bleeding aneurysm? No, you can't say that. I can't say that. Can you say that they do have a bleeding aneurysm? No, I can't say that either. I just don't know. I need more information. And I would say the same thing for tumor, meningitis, migraines, and sinusitis. So we've created now a differential diagnosis, but we need to get more information. So let's do that. So for this list of diagnoses, we decided we didn't know whether they had them or not, so we need to test further. So what's the next source of information that we can get data from? Well, it's the patient. We can start asking them questions. And when we ask questions of a patient, we call that taking a history of the patient's illness. And there are some common questions that we ask of everybody, and we use this mnemonic OPQRST, and what that stands for, when did this stuff start? What's the onset? Where does it hurt? What's the position? What does it feel like, the quality? Does it move anywhere? What does it radiate? How bad is it? Maybe on a scale from 0 to 10, the severity, and how long has it lasted, the timing. So in addition to these general questions, there are also specific questions we ask. So for aneurysms, we might ask, is this the worst headache you've ever had? Did it start suddenly? Did this thing cause you to black out? Or do you have any family members with aneurysms? And there are specific lists of questions that you would want to ask for patients if you're considering brain tumors and meningitis, as well as all the other things that were on our list. And so we should ask those questions in our history. And you're going to want to make these lists of questions that are specific to these diagnoses. We call this thing an illness script. So let's say we ask all these questions, and for a bleeding aneurysm, we're not exactly sure whether they have them or not yet. So we're going to put that in our list of, I don't know, I need further data to make that. For brain tumor, let's also say that we weren't exactly sure whether they had the brain tumor, so we're going to put that in that pile. Now, meningitis, patients with this tend to have fever and maybe some sick contacts, and they're in close quarters with them, and our patient really just doesn't fit that description, and we feel pretty confident that they don't have it, so we're going to put that one in the trash. And similarly, for carbon monoxide poisoning, that tends to happen in the wintertime when people are turning on their furnaces, and that causes the carbon monoxide leak. And it's the summer now, so we don't think it's that. And there's nobody else at home who has headaches or vomiting, and the dog is not puking. And so we also feel that carbon monoxide poisoning is of low suspicion, so you know what, we're going to throw that one in the trash too. Now, migraines and sinusitis remain here, so we asked our questions about migraines, and our patient does have a history of migraines, so we think, hey, it's possible. I think we need some more information on that one. Sinusitis, the patient doesn't have any symptoms consistent with that, no sinus pain, no sinus discharge, and you think, you know what, I feel pretty good that this patient doesn't have that. I'm putting that one in the trash now, too. Now, if you look, none of our diagnoses we were confident enough to initiate treatment. We got rid of a whole bunch, but we got some more that we need to do, gather more data for, so let's do that. So now we have these diagnoses that we need further information for, and what's the next source that we can get data from? Again, from the patient. We're going to do a physical exam. That means we're going to examine them. So you're going to learn how to do all sorts of exam maneuvers, including listening to the heart and lungs, feeling the belly. But in this case with the headache, what's also important is to do a good exam of all the brain function and neurologic function. So you're going to learn all of those skills, and let's say that you do those. And just like each disease had an illness script that said which questions you should ask of the things that the patient may complain of, it also on that illness script has which things you should look for when you're examining the patient. So for an aneurysm, you might look for some of these things, like a stiff neck or they're confused. Tumors and migraines would have other things that you may look for. So let's look at our differential again, and let's say that we feel like we still don't have enough information to say that our patient does or does not have a bleeding aneurysm. We need more data. Let's say for a tumor, our patient's neurologic exam was great, and we felt like this patient doesn't have it, so we're throwing that one in the trash as well. And migraines, we didn't have enough information either way to say they had it or didn't have it, so we're going to put migraines in test further. So you can see how we use these illness scripts in order to know which questions to ask, as well as which things to look for on your physical exam. And then we tried to match that with what the patient actually had. And it'll never be a perfect match. And based on that, we decided we could get rid of some differential diagnoses. We haven't found any that we're going to treat yet. We found some that we still need more information on. So guess what? We need to gather more data and then interpret it. So now we're left with these two diagnoses we need to get more information on what further data can we get. Well, we could do testing. What kind of testing can we do? Well, there's all sorts of testing that's available. We can do check blood and body fluids, as well as imaging. And imaging includes things like CAT scans or X-rays or ultrasounds. And so we can do further testing. And so luckily, we look back to our illness scripts again, and remember it told us what questions to ask on our history, what to look for in the patient on our physical, but it also tells us what kind of tests we might want to do. And it says a brain scan and a spinal tap are possibilities. And There's probably similar things for migraine that we can look for. And so let's say that we do our brain scan. So first I'm going to move these diagnoses over here. We do our brain scan, and lo and behold, we see something on here. We see this stuff here. Now, on a real brain scan, blood does not look red, but for my drawings it does. And you see bleeding there, and you say, oh, okay, that really makes me think this is a bleeding aneurysm. In fact, so much so that I'm willing to start treating it. So we move bleeding aneurysm to the start treatment category. And so we initiate the proper treatment for that and get our patient taken care of. Now, migraines, that's still left here. Does the patient have migraines? Probably not. If they have a bleeding aneurysm, we might say that because we already found an explanation for this, my suspicion for this is low, I'm going to put that one in the trash as well. So let's review what happened here. We started with a patient who came in with a complaint. And then remember, our goal was to come up with a diagnosis that we could treat. Then we went through our clinical decision-making process, which was basically just cycling through this, gathering information and interpreting it, and then making and testing our hypotheses. And we went through it, gathering data from several different sources. In this case, we gathered it from our nurse, we gathered it from the patient's history, physical, and testing. And each time that we did it, we compared it against our illness scripts. And we used our differential diagnosis to look at which illness scripts we needed to look at. And we made a decision whether we needed to discard that diagnosis, whether we were able to treat it, or whether we needed more information in order to test further. And ultimately we came up with a diagnosis that we were able to treat. Now this is a lot. I just wanted to show you in one very simplified example the sort of things that you're going to be learning. And we're going to go through each one of these throughout all 4 of your years, refining it and improving your skills in all of these aspects. And so, welcome to Rush Medical College. I just wanted to start you out on our practitioner curriculum with some clinical thinking skills. Thank you, and please feel free to email me if you have any questions. Bye.